Quinn is a phenomenal superstar researcher. Cliff and I have decided she's already PI. Given the study she's running, she's like PI level. She's the chair. She's also going to present. And she's going to also start with grounding us in our, so that our mind reaches our body and we're not traveling in time. And it looks like she's coming. So I guess I'll use this time to announce that there are strong winds tonight, starting at 2 a.m. And we're in the Santa Cruz Mountains, and they often cause a blackout. So charge your phones tonight, and you have an email describing what to do. We all have flashlights in our rooms attached to the power outlets. So that will be exciting and cozy. But since you definitely need to, you know, the phone is the key to Uber and other things tomorrow, you want to charge it tonight. Thank you.
All right, so welcome back everyone for our final panel of the day. I would like to start by inviting you to just take a moment to orient yourself and to look around the room and notice whatever it is that might bring you joy in this moment, or that might signal to you that you are in a safe place. It might be the friend sitting next to you, the view of the redwoods standing outside, or the sight of your colleagues' masked faces as we take care of each other during this pandemic. As we have heard throughout the discussions over this weekend, we are all collectively facing a number of different grand challenges, and each one of these can be overwhelming individually, but collectively they can be nearly paralyzing. So the question before us is, how do we stay engaged? And it is my pleasure to invite our panelists today. These are all world-renowned researchers who study contemplative practices, so meditative and contemplative practices, including mindfulness and compassion, and how we can use these practices to skillfully navigate what it means to be human, our interconnectedness, our impermanence, and the inevitability of sickness, aging, and death. So I will now turn it over to Cheryl. Cheryl Giscombe. I will skip the introductions because we are all running a little late. So go ahead, Cheryl.
Okay, thank you, Quinn.
Thank you.
Okay. Well, good afternoon, everyone. I'm really excited to be here with you, and I'm going to try to stick to my slides so I can be respectful of my colleagues so all of us have the time we need to present. I want to be grateful. I want to express gratitude for research funding sources that have supported my work, and the institutions, the educational institutions that have allowed me to grow to do the research that I do. So you might already be able to tell from my accent, North Carolina is my home. And in North Carolina, at least for me and the people that I'm around, y'all means everyone. And I want you to know that you may hear lots of things about North Carolina, but there are communities that are accepting and open and inclusive, and I want you to know you're welcome at any time, so let me know when you're in the state. Our state is very diverse. 62% of the population responded to the US Census as white only. So we have about 21% African Americans, the largest population of Native Americans or American Indians east of the Mississippi, and a growing percentage of Latinx communities who are about 10%. Also growing Asian population, so it's just a right place to study health and health disparities. So I just like to always acknowledge the tribal communities of my state in the work that I do. And I also acknowledge my family. And I always have this slide, or often over the past few years, because it grounds me to see my family. And I put it there not knowing what the connections are going to be, but now the dots are starting to connect in terms of mindfulness, resilience, connectivity, and health. And I'm going to tell you a little bit more about that. I love genealogy. So when I don't feel like doing my academic work, I'll read resources that one of my cousins who's a genealogist has done. And what you can see here, the top far, I guess it's on your left person, is my third great grandmother. My family on my mom's side still lives in the same area where we can trace our roots back at least to 1768. My fourth great grandmother, her name was Edie Carter, and she's like the mother tree. I went down to see the mother tree. And if you haven't read about the mother tree on the 1440 website, I suggest you do, because it might have some implications for mindfulness, resilience, and connectivity, and the missing pieces of wellness and well-being that we're all seeking. So as I think about this, I also think about a recent resilience review that I did with some colleagues, where what we identified is that in measuring resilience, we're operationalizing it for African-American women. It's important to also include cultural identity. That's a resilience factor that's not often on resilience scales. So again, the dots are starting to connect for me, and maybe why I seek the connections to my family. And what I want you to see, this is not the mother tree down the hill. I actually went to the land. I've always been on that land when I visit my grandparents, but I walked on a part of the land that I've never been, and I saw this large tree that, according to my family, it's been there for a long period of time. And in awe of this tree, I noticed that I was in a state of mindfulness in nature, feeling calm and secure in the silence of nature. And so Camille Wortman, many of you may know her, but she taught my stress and coping class in my PhD program in social and health psychology, and she encouraged all of us to do what we think about in the shower. So what was I thinking about? When she says, think about what you're doing in the shower, she means when no one's telling you what to think about. And since I was a teenager, I was always, really interested and intrigued by stress and coping, but also mental health, physical health. And then as I grew older and took classes in high school and college, took classes in history, world history, US history, African studies, and it's all coming together. And of course, we're here today to talk about health disparities, at least during my segment. And one of my favorite quotes is, of all the forms of inequality, injustice in health is the most shocking and inhumane. But mindfulness may be a source of hope and well-being at both individual and structural levels. So I'm going to talk to you about my work at UNC Chapel Hill, but first I want to invite you to take a look at this image just for a few seconds and notice what's going on in your mind, your body, maybe even your spirit as you're taking in this image. And then this image. Just note to yourself what you're feeling. Maybe you were very present just in those few seconds. So what is mindfulness? The intentional self-regulation of attention to present moment experience. Elements of mindfulness include paying attention on purpose in the present moment without judgment in the service of self-understanding and wisdom. At least that's one of the common definitions, but in conversing with my colleagues yesterday at lunch, I added this quote from Jon Kabat-Zinn, which helps us to remember that mindfulness is also heartfulness. So you could think of mindfulness as wise and affectionate attention. So you may be aware there's 7 major pillars of mindfulness, at least according to some philosophies. And we may get to this in the discussion, but I want to move along. MBSR is probably one of the most commonly utilized mindfulness-based interventions and research, which involves both formal and informal practices. But also reflective practice, contemplative practices, those are also important elements of mindfulness that may or may not be utilized in MBSR. So you can think about music, arts, humanities, nature, as I talked about before. But mindfulness cultivates those heartful qualities, such as non-judgment, acceptance, patience, which may lead to things such as enhanced spirituality, enhanced insight, increased empathy, gratitude, and compassion for self as well as others. Research, a large body of growing research on mindfulness, has shown both mental and physical health benefits in studies that are now becoming much more rigorous and sophisticated with RCT designs and subjective as well as objective measures of outcomes. So we know that if mindfulness has these potential benefits and these evidence-based benefits, it's maybe useful in clinical care, which was described to us today. The ED visit recommendations included mindfulness. And a large and growing percentage of people in the US and worldwide are using these techniques because we know our world is highly stressed. But mindfulness is a universal concept. Sometimes we relate it to one major, I guess, culture, Eastern culture, but it's universal and present in many ancient and indigenous societies. And we think about when we say mindfulness, what is the mind? Is it the heart? Is it our psyche, meaning our mind, spirit, soul? Is it the central force in thought, emotion, and behavior as we define mind in psychology? But what I'm interested in is the potential effectiveness of mindfulness for African-American women who suffer from stress-related disparities, as well as other groups who suffer from disproportionately high rates of chronic illness that are stress-related. So I'm going to talk to you just a bit about my research, a series of studies since my doctoral program under the mentorship of Marcy Lobel, and now independently in my research at UNC Chapel Hill. So let's focus a little bit on African-American women. You can see from this list some of the chronic illnesses that are disproportionately represented in African-American women. And in this blue circle, I have some of the theoretical frameworks that I use in my research to help me understand how to study stress and chronic illnesses in African-American women. And I also want to just highlight the bioecological systems theory, especially when we think about individual versus structural interventions. So we're individuals living in this context of multi-levels. And so when we think about interventions and also understanding, mechanisms, we want to think about all of these levels. And what I love about the bioecological systems framework is that it also involves the chronosystem, time and historic influences, which we often forget to measure or even consider in our research. So what about this concept of social determinants of health that we hear so often? We know that stress is one of the major determinants of health, which can influence health behaviors as well as physiological responses. And I couldn't have this slide without honoring the great Dr. Norman Anderson, who really inspired me in my research to think about racism as a stressor and as a biopsychosocial factor in health disparities. And if you want more information about this, you can look at the commission report under the leadership of Dr. Anderson that many of us here in this ABMR group were part of, this Stress and Health Disparities report, which can give you more information. So again, disparities are shocking and inhuman. Without mental health, there can be no true physical health. And when we think about mental health, I'm a psychologist, I'm a psychiatric nurse practitioner, I think about the spectrum, but today I'm going to talk about stress. So early research on stress helped me that should be biopsychology, engage in biopsychology, this discipline of Black psychology, as well as US history, which helped contextualize my questions. I worked in the lab of Kathleen Light, the Stress and Health Lab, where I learned laboratory and ambulatory stress reactivity research in terms of CV risk. And also, as I mentioned before, Dr. Marcy Lobel's work was pivotal for me because when I learned of the disparities in birth outcomes among African-American women, when we compare them to white women, I was alarmed. And what I learned was that we need to do a better job in measuring stress. So I was called to action because if we think stress is a factor in these disparities, how do we measure stress? In order to measure it effectively, we need to use culturally relevant definitions and ways of operationalizing stress, including race and gender. As you can see here, race and gender matter. So we must understand these things about stress in order to develop targeted interventions. So another concept that I include in my research that is targeted through mindfulness is this concept of superwoman schema. It's a conceptual framework that I developed that has 5 characteristics listed here: perceived obligation to present an image of strength, perceived obligation to suppress emotion, resistance of support or vulnerability, motivation to succeed despite limited resources, and prioritization of caregiving over self-care. And it was important for me to kind of understand these factors when we think about stress, obesity, the existing interventions that did not really address obesity in Black women, and how obesity is so critical in terms of its risk for chronic illness and putting women at risk across the life course. Even though these factors may seem like limitations, women see them as a double-edged sword that contribute to both survival and limitations. So survival of self and community, but also neglected self-care. So on the outside, and many times even on the inside, women may feel strong, but they might also have experiences of feeling overwhelmed and distressed. And so I just have to acknowledge some of the previous research that informed my thinking about these concepts. John Henryism, Sojourner syndrome, as well as the psychological concept of network stress. So what I wanted to do is address the fact that our strength might be a double-edged sword, an asset and a liability, contributing to resilience and fortitude, but also an overused asset that becomes a liability because it's not changed when it needs to be changed in certain situations. So the framework involves the characteristics, but it's also rich in that it includes the antecedents. People just don't have these characteristics for no reason. They're antecedents and of course outcomes. So in order to do research on interventions, we first have to measure this concept. So I developed a measure, did at least three studies and now more, but initially 3 studies to try to understand the psychometric properties of superwoman schema. And now we know that it's associated with certain things as depressive symptoms, stress, allostatic load, stress-related eating, poor sleep quality, et cetera. And you can just see a list of studies here. This is just a sample of other researchers who are using this measure in their research, including Dr. David Shea. And so with Amani Allen at Berkeley, we've looked at allostatic load in superwoman schema, and it's helping us to target interventions towards which factors of superwoman schema might be amenable to a mindfulness-based intervention. So if superwoman schema influences stress, how then does it lead to mechanisms that lead to higher levels of cardiometabolic risk? So in comes mindfulness. And I'm going to wrap up just quickly because I just want to give you a little sample of the research, and then I'll answer more questions at the end. So the benefits of mindfulness, self-awareness, loving kindness, and self-care might help to address the liabilities of superwoman schema, but help women enhance the parts of superwoman schema that are beneficial. But what we know is that mindfulness is culturally relevant for African Americans, and particularly those in the Southeastern United States, through our research on cultural relevance of mindfulness. We also know that mind-body interventions are ripe and appropriate for stress-related disparities, and even that they're related to ancient traditional practices that African American women's, their ancestors may have practiced over many years and generations. But through biobehavioral research, we're able to test mindfulness not only with subjective outcomes, but also objective outcomes in our biobehavioral laboratory at UNC Chapel Hill. So currently we're working on a study called Harmony, which is based on our pilot research on mindfulness-based intervention for pre-diabetic African American women. And in that study, we found that mindfulness reduces stress, it improves eating behaviors, and it also has implications for reduced inflammatory markers. And what we found also, though, is that in our research, women reported that they don't practice mindfulness as much as they'd love to because of those caregiving responsibilities. So we have modified the mindfulness intervention to specifically address superwoman schema characteristics in African American women. I'm going to skip ahead with the study called Harmony. And the Harmony study is an ongoing R01 randomized controlled trial with African American women. We're addressing physical activity, healthy eating, and mindfulness to target the characteristics of superwoman schema that might be detrimental to positive health outcomes, and specifically cardiometabolic risk. So I'll pause here and I look forward to talking with you more. Thank you so much.
Thank you, Cheryl. Next, we'll hear from Linda Carlson from the University of Calgary.
All right, well, I'm waiting for my slides. My mic, I just want to say thank you so much, Cheryl, for that wonderful talk and such a beautiful program of research, and also for doing such a good job of introducing the concepts of mindfulness and some of the attitudes. So I will try and stay in my 10 minutes as well. I was given a title, Mindfulness and Emotion Regulation in Cancer Survivors, so I will talk about that, but hopefully I'll slip in a few other things as well along the way. So really, why would mindfulness-based interventions be specifically appropriate for people living with cancer and other chronic illness? I'll describe very briefly our program. It's just an adaptation of MBSR called Mindfulness-Based Cancer Recovery. Talk about 2 clinical trials that we've already done, and very briefly mention some ongoing work in a few minutes if I have the time. All right, so why would applying mindfulness, as described nicely by Cheryl, why would that be specifically beneficial for people dealing with acute and chronic illness? So look at the spider. He says, "You got to help me. I just seem to be spinning out of control," which is a fine feeling for a spider, but not so good for a person. right? I've heard people say in these talks that we like to feel like we have a sense of control over our life, but the only certainty in life is change. So there's a disconnect there, and it's brought into the forefront when you're diagnosed with cancer or another illness. Loss of control. So you thought you know how your life was going to look. You thought you would retire and travel the world and spend time with your grandkids or whatever, but no, actually now you might have to face the end of your life much sooner than you probably anticipated. You don't know what your prognosis is. You probably don't even know what your treatments are going to be. You really have very little say over how that's going to go. You have to face the existential issues of the life threat and the loss of just predictability and routine in your day-to-day experience. There's many emotions: grief, fear, anger, depression are just a few. Shame, guilt, blame, you can add on that depending on the cause and type of cancer. The fatigues related to the illness itself and the treatment, pain, fatigue, sleeplessness are very common. And no matter how good the prognosis, there's always the fear of recurrence. When is the other shoe going to drop? So every ache and pain can become a major health crisis. Well, it turns out, amazingly, actually, that the skills and the attitudes cultivated and developed and applied to training and mindfulness, such as emotion regulation, acceptance of things we can't change, learning the difference between where we do have some autonomy, non-attachment to experience, letting go of outcomes, and self-compassion can be so helpful at these times. So we developed the mindfulness-based cancer recovery program based on MBSR, adapted to some of the specific issues of people with cancer. And we started as an 8-week, now we're a 9-week intervention. It's fairly standard in terms of its setup. We have 2-hour weekly meetings. It goes through a progression where there's always a introductory meditation, a discussion around home practice, some educational material. And then we spend half of our experiential time with mindful movement and the other half introducing different types of meditations. So, we follow the program with a booklet. They do home practice every day between 30 and 45 minutes, keep a log, and we have a silent retreat. So over the years, my colleague who developed this program with me, Michael Specka, and we wrote this book, Mindfulness-Based Cancer Recovery. It's for patients. It's designed as a home study program. People can follow through it. There's guided meditations. It's available in a whole swack of languages right now, and a few more beyond this as well. So we've been really pleased with that ability to enhance reach of the program. So it's a multi-component program. The overarching theme is mindfulness. We teach people how to relax themselves if they choose to, using things like abdominal breathing. The yoga is really important and central in this group, which I'm happy to talk about more afterwards. We emphasize the mind-body connection. We teach them a bit about psychoneuroimmunology. We use visualization and imagery as techniques. There's also the sort of piece from mindfulness-based cognitive therapy where we talk about the stories we tell ourselves and how they influence our experience and can cause suffering. And there's an element of personal empowerment that brings back a little bit of that sense of control. And of course, there's social support. So, for people who like dismantling or like to know active ingredients, this is a tough one because it's very sort of multi-component intervention. And I think David's going to tackle that one a little maybe. So the different practices, we do the body scan where they're lying down, sitting meditation, walking practice, open awareness meditation, imagery like mountain and lake meditations, and of course also an element of self-compassion and loving kindness. All right, so we've been doing research on this for quite some time. This is the first study that was ever published on mindfulness for people with cancer that we started in 1998 and published in the year 2000. And really, we just developed this program. We took anybody who would sign up for it. So we had 89 participants. It was a randomized waitlist controlled trial. They could be any kind of cancer, anywhere in their treatments. We're happy to take them. And so what we found was really large improvements in stress, like effect sizes that were like 1.5 or something crazy like that, and also mood disturbance. And we followed them up for 6 months and saw maintenance of those improvements. So really, this was at the point where I was starting my postdoc, and I sort of took this on as a project, investigating this program. So I'm going to skip about 15, 20 years here and just show you a summary of some of the other research. So we've looked at all range of symptomatology, stress, mood. We see improvements in anger, anxiety, depression, improvements in sleep and fatigue. I'm going to tell you about some of the mechanistic work around rumination and worry. And we've also looked at partners and shown improvements there too. We've looked to not only sort of treat negative symptomatology, but also see in what ways does this help enhance a sense of spirituality or connection or meaning and purpose in life, and shown through qualitative and quantitative methodologies that this is really a central part of the program as well. Because I have a background in PNI, we took lots of blood samples, saliva samples, looked at blood pressure, cortisol, inflammation, telomere length. We're looking at gene expression, all kinds of fun things there. You can find all those publications on my website. So these are some of the clinical trials we've finished recently, and I'll tell you about the ongoing ones if I have some time. So I'm just going to tell you about Mind in Motion and Master. So Mind in Motion was our attempt to look at mechanisms of change, specifically focusing on emotion regulation. And so we thought that some of the emotion regulation mediators of change we see in symptoms might be related to the development of facets of mindfulness. So there's a questionnaire, the 5-facet mindfulness questionnaire, that looks at 5 different skills or facets that one would develop in a mindfulness practice. So observing or just paying attention to both inner and outer experience, non-judgment, so seen as a sort of separate component. So cultivating that quality of not evaluating or judging experience, just accepting it for what it is, the ability to describe our experience. So sort of that's a bit separate, that's putting language onto the experiences that we observe, acting with awareness in our everyday life, as opposed to sort of mindlessly doing things on automatic pilot, and not reacting to the emotions or the thoughts or the feelings we have kind of in a knee-jerk fashion. And so the emotion regulation measures we were interested in that we know are associated with symptomatology or worry. So of course, that tends to be perceptive thinking that's future-oriented and generally negative. Rumination, which is also negative perceptive thinking, but usually about the past. So, why, or I shoulda, coulda, woulda. And so there's regret, there's anger, there can be depression. Whereas worry is associated more with, sort of stress and anxiety. And experiential avoidance. So often people avoid their emotions, whereas mindfulness practice is about actually creating a safe container to pay attention to your emotions and to be with them, watch them shift and change. So the opposite of that would be exposure to difficult emotional experiences. So we were interested in that as well. So the way we did this was a waitlist controlled trial. We had 211 participants, and they were either immediately taking the program or on a wait list. And we added in a midway assessment so that we could look at timing and sequence of change. So we assessed them at baseline, halfway through the program at 4 weeks, after 8 weeks, and of course, while the waitlist group was just waiting. So we were trying to look at the effects of these putative mediators on stress and mood as outcomes. So we tested all those different mediators. We also looked at main effects and interactions over time. And as I said, tried to really look at timing and sequence of change in the development of these different facets of mindfulness and emotion regulation. So here's the study that came out. This is kind of the model we were testing. So looking to see if participation in the group would affect the different mindfulness facets, which would then perhaps directly affect psychological functioning, or maybe affect emotion regulation, like strategies like rumination, worry, experiential avoidance, which would then either directly or indirectly affect the outcome. So we tested a whole bunch of these different pathways. So we had an average of 53-year-old, kind of typical, actually fairly highly educated, mostly female, mostly white, mostly breast cancer, about 2 years since diagnosis. And so we found the usual group by time interactions on all the outcomes. So those are the effect sizes in the very last row. So those are all the outcome measures and also the mediators. So basically saw that through piecewise HLM, that from the beginning to the end, all of these things improved more in the mindfulness group than in the control group, anywhere from medium to large effect sizes. Oops, whoa, what happened there? Okay, timing and sequence of change. So we did the baseline assessment. The immediate group did their first half of the program. We reassessed them, and what changed? What changed was noticing and attending to experience. So observe, the attentional capacity to observe your experience was the first thing to change. Non-judgment also changed early in the program. But also we were surprised that rumination and worry changed so early in the program. But they did, they changed most in the first 4 weeks. The group continued on, finished the program, and we reassessed them again. And what changed in the second half of the program? The ability to describe or emotionally label the experience, the actual acting part of acting with awareness, non-reactivity to experience. So that took longer to develop the capacity not to have the knee-jerk reaction, and experiential avoidance. So the more behavioral things changed later in the program. And at the very end, also the things that changed were stress and mood, kind of our symptomatology outcomes. All right, so we did a series of, mediation analyses. There we go. And so this is just an example of sort of looking at the way, what mediated change in the other outcomes. So being part of the mindfulness group changed non-judging, which then changed non-reactivity. So that was partially mediating those changes. So it's actually taking into account all the other things and showing that participation in the group was associated with early change in observing, which was associated with later change in describing experience. And another mediation that was significant was attending the program, changes in rumination leading to changes. So rumination actually mediated more outcomes, observing, non-reacting, and avoidance of experience. And the only mediator of actual symptomatology, so this is kind of against what our hypotheses were, was worry. So if your worry changed early in the program, you had lower levels of stress. Makes sense, right? Well, there you go. So in summary here, some facets of mindfulness like observing and non-judging develop early in the training. These earlier changes mediate later changes in other facets. And the rumination mediated later changes in mindfulness facets, experiential avoidance, and worry mediated stress. Okay, it hasn't buzzed yet, so I'm going to keep going.
It has.
It did? I didn't
Yes,
hear it.
it wasn't loud enough.
Oh, was it a long time ago?
Yeah, it's a good time to transition.
Aye. Okay, ask me about this study because it's a Trier social stress test. I'll leave it. I didn't hear it. Oh.
All right. Is my mic on? Oh, good. So hi, I'm David Creswell. I'm a professor in psychology and neuroscience at Carnegie Mellon, and we study stress and resilience in my lab, and just really had the great fortune to spend many years now studying mindfulness meditation interventions and practices. And I want to talk a little bit about acceptance and equanimity skills. I appreciate Alyssa putting the equanimity mind piece up there, sort of saying this is the first time equanimity might be at a major conference. So I want to actually take a deeper dive on that particular issue. For many years now, my lab's really focused on really trying to think about how mindfulness meditation and mindfulness meditation interventions become biologically embedded. And, so how they're changing the brain, how they're changing stress resilient circuits in the brain, how that's changing our stress biology in the body, and how that's changing over time, a broad range of stress related health and disease risks. And so we've been really working hard on this sort of, how does mindfulness training get under the skin to influence health for a long time. I actually have talked to this society a little bit about this account, but what I wanted to talk to you about today is something we've been working on really over the last 5 to 6 years, which I think asks a little bit different question. It really asks, what are the behavioral skills people are learning that really kick off these sort of biological cascades? Like, how is it that mindfulness meditation changes the brain and changes our stress physiology over time? And that's what I want to talk to you guys about today. I think it's really interesting. And where we started with this was really asking the question, what are we doing when we do mindfulness meditation? And, I could, mention some of the examples. Some of you may have done some of the meditations, and, one common prompt is to have you, close your eyes and just pay attention to the sensations of breathing at your nostrils, right? Breathing in, breathing out. And you might do that for a little bit, maybe just a couple of seconds, and your mind wanders, right? You're thinking about dinner later, thinking about that amazing meditation symposium. But the instructions in these meditation programs are really to notice where your mind has wandered and then bring it back to your anchor, in this case, the sensations of breathings. And by doing so, you're really training this sort of set of skills on attention monitoring. You're really learning how to use your attention to sort of bring it back when it wanders. And these are sort of like attention reps. And in fact, these attention monitoring skills have really dominated the sort of mindfulness meditation landscape, right? People talk about meditation training as being attention training. And they talk about mindfulness as a sort of, present moment awareness. And in fact, our argument has been, hey, these skills are really important. You can train your attention and they may have benefits. But there's actually a second category of skills that people learn that are these acceptance and equanimity skills. So I could take you back to doing this guided mindfulness meditation practice. We're paying attention to the sensations of breathing as we breathe in and breathe out. And maybe a minute in, you get that itch, or you get that discomfort in your knee, or you get a sensation of agitation or boredom sort of arising. And the mindfulness meditation instructions are pretty clear. You're to sort of bring an open curiosity to what these sort of slings and arrows are of doing your meditation practice. You're to acknowledge, sort of gently acknowledge those experiences, accept those experiences, and then return your attention, back to breathing. And so in some sense, you're really doing these equanimity reps, right? You're sort of working with your attention in a particular way. You're fostering this attitude of openness, non-reactivity, and non-judgment. And these acceptance and equanimity skills, they get sort of put into mindfulness interventions in the back door. You kind of hear about them, but a lot of the attention has been really on these attention monitoring skills. And our argument really has been that learning how to be more accepting and equanimous, sort of practicing this with all those benign slings and arrows during meditation practice, you're building this equanimity muscle. And in fact, that's the sort of key element for helping you then manage your emotions, manage stressors in your life in ways that might then have protective effects over time with a broad range of stress-related disorders and diseases. So we built out an account for this called Monitor and Acceptance Theory that really, this was with Emily Lindsay, her picture's here. She was a graduate student of mine. She's now a faculty member at the University of Pittsburgh. So her name is all over this stuff. And we built out this theoretical account, which really argues that, hey, these attention monitoring skills are important. They're helping us to focus our attention, improving cognitive performance. But in fact, those skills alone can heighten our affective reactivity, right? You tell someone who's having a panic attack to sort of pay attention to their breathing, it's going to ramp up their affective reactivity. But critically, that these acceptance and equanimity skills really may be the key driver for mindfulness intervention effects in terms of facilitating emotion regulation, fostering non-reactivity and non-judgment, and that these acceptance skills really may improve stress resilience and stress-related health and disease outcomes, and really may be the sort of key driver for this sort of stress resilience effects and the biologic embedding that I mentioned earlier. Our original theory paper, we really pulled on a lot of correlational data looking at these mindfulness self-report instruments that measure attention monitoring and measure these more acceptance or equanimity skills, and showed some initial sort of correlational data to suggest that this account may have some wings. But we really wanted to do some more experimental work, and we did now a couple of randomized control trials where we really tried to experimentally test this account. These were pre-registered trials in clinicaltrials.gov where we had very specific predictions about when we would see stress buffering effects. I'm going to tell you about one of those trials today. In the interest of time, I'd love to tell you about others, but I'll just tell you about our smartphone training randomized control trial. We recruited 153 stressed community adults. These were otherwise healthy community dwelling adults that had high perceived stress scores over the past month. And in these randomized control trials, we adopted a dismantling trial approach. So these were, and maybe I'll say one thing first about what we gave folks. We gave them 14 days, 20 minutes a day of training. and it had some homework prompts in it. This was delivered via a smartphone app. In our sort of full-blown mindfulness training condition, we call this monitoring accept, or MA. They did this 14 days. It was sort of standard mindfulness meditation training. You're learning these attention monitoring skills, learning how to be really present with your experience, but to develop this attitude of openness and curiosity, these sort of acceptance and equanimity skills. This is sort of standard off-the-rack mindfulness meditation training. But critically, our second arm was attention monitoring skills only. So you're still learning how to be present, to really ground your attention in present moment experience, but we weren't layering in those terms around being open and accepting and non-judgmental toward your experience. Same dose, we gave folks got a lot more attention monitoring training in the monitoring only group. And then finally, this was a placebo-controlled trial. We developed a stress management training program that was really focused on sort of principles on problem-focused coping. So you're learning how to analyze stressors in your life and problem solve. Folks really liked it. We called it My Time. This was actually an effective placebo control. We did some measures of treatment expectancies. We see similar treatment expectancies across these three groups. So folks really like these programs and like the smartphone training context. We had great adherence. Folks did these lessons, and we had a very low dropout rate. I think it was around 3 or 4% in this trial. 3 or 4% at follow-up. Eventually, my slides will kick in. What we also had was 3 days of experience sampling before and after the 14-day program. I can't advance. We don't need slides, but oh, I'm going way ahead. Okay. Cool, I'll just sort of guess and see where we're at. So anyway, we did 3 days of experience sampling. So we had EMA, and we had daily diary assessments for a couple days before and after the 14-day training program. And then we had, is it there? A post-treatment lab session where they got a 20-minute booster session that was sort of mimicking one of the days of their 14-day treatment, and then they went into the Trier social stress test. Folks know in the society the TSST really well. 5 minutes of speech, 5 minutes of difficult mental arithmetic under harassing conditions from an evaluative panel. It's a dreadful experience. Reliably activates, HPA and sympathetic nervous system activation. And so one question we had was, does 14 days of mindfulness training sort of buffer, biologic stress reactivity to this task? In our control group, that's in the dotted line here. This is looking at cortisol slopes. We get a nice, reliable increase in cortisol reactivity to this task, as you normally expect. So folks who got the sort of problem-focused coping stress management training showed this, sort of standard cortisol reactivity pattern. But folks who got full-blown mindfulness training, we showed this really nice stress buffering effect, showing reduced cortisol reactivity.
David, your 10-minute warning just went off. So
okay, everything's falling apart here, folks. There it is. Okay. That thing is really distracting me. So I'm going to come up here and I'll go this way. We got this really nice stress buffering effect with our 14-day training. But critically, to really test this account, what happens when we take out those equanimity skills? We really show that same sort of stress reactivity pattern. When we do these pairwise comparisons, the monitor only group looks more like our control group. And so really some suggestive evidence here that learning these acceptance and equanimity skills really may be a really important component for stress buffering effects, at least to acute stress challenge tasks. I mentioned, I'll just maybe say a couple of things really briefly. We did 3 days of experience sampling, and what we're finding is that we're not only seeing these stress buffering effects, but there seems to be a really interesting carryover effect of learning these acceptance and equanimity skills in terms of your daily life functioning across different domains. So one thing we're finding is that it seems to, learning these acceptance and equanimity skills really seems to boost your well-being in daily life, your ability to sort of savor and appreciate moments of positive affect. So we see this with well-being, and we see this with quiescent positive emotions like sense of calm. So really learning these acceptance and equanimity skills has a lot of value for well-being. We also see these cool social benefits. So learning these acceptance and equanimity skills not only makes you sort of more open to your experience, but more your ability to connect with others. So we found that it reduces people's loneliness and also increases their capacity to make more meaningful social interactions after the 14 days. And so we have another paper on that if folks are interested in those findings. So let me wrap up real quick. I think that we're just really excited about this account and sort of starting to really study the science of learning acceptance and equanimity in your daily life. And I think this account really helps, I think, push forward thinking about mechanisms of mindfulness intervention effects. And it really focuses on behavioral skills. And we have, at least with our initial trials, some really, I think, promising evidence to suggest that it can impact stress reactivity and then also impact daily life functioning in a number of domains, not only well-being, but in social functioning domains as well. We're moving this, we have a new R01 to look at this and move it into patient populations. So we've got a big randomized control trial where we're going to look at this in irritable bowel syndrome patients. We're going to be looking at gut microbiome in that project. So that'll be one of the first trials to look at stress management training, modulating gut microbiome. But critically, we're going to be asking questions around whether learning these acceptance and equanimity skills may not only reduce stress, but impact symptoms and disease pathology in that group. So just to wrap up, I think there's some implications for thinking about equanimity in the science that we do. First is that I think that it's really important for potentially expanding our basic science agenda in terms of thinking about emotion regulation. I know Linda sort of talked about emotion regulation in her work, but a lot of that emotion regulation literature is focused on cognitive reappraisal. And I think that these acceptance-based approaches may hold a lot of translational power for thinking about emotion regulation in important ways. And I can say more about that if folks want to talk about it. I think these skills may be a common transdiagnostic mechanism for a variety of interventions. You know, people who go through psilocybin treatments, CBT treatments, expressive writing treatments, really talk about this capacity to be more open and receptive to their experience. And so it may be a real potential lens for thinking about mechanisms in these other interventions. And then finally, to sort of wrap up, I think that a lot of people who are delivering mindfulness interventions, you know, focus a lot on the presence and the attention pieces of mindfulness practice, and maybe less on the attitude and ways that we can relate to our experience. And I think that thinking about acceptance and equanimity approaches really suggest ways that we might want to make mindfulness interventions more efficient and effective by really letting folks know, hey, when you're sort of doing those equanimity reps, when you're dealing with difficult experience and you're working with that, that's actually where a lot of the action is for these mindfulness interventions in terms of mechanisms of change. I've conflict of interest disclosures. We got some money from Headspace to do a project. I've got a new company that's really spinning out a lot of this work to build a new mindfulness meditation app that really focuses on these skills. And I want to just thank all of my collaborators and funders. Thanks.
Next, we'll hear from Dr. Cliff Saron from the University of California, Davis, and my advisor.
And Dr. to be Quinn Conklin. So while I'm waiting, there's something really deeply ironic about 10-minute talks about meditation and slowing down. So I just want to name that. Slow elephant in the room. So I've been interested in the topic of attention and meditation for some time. Here is a picture of Richie Davidson in 1992 on a goat trail in the foothills of the Himalayas, and we're on our way to see a monk who's actually doing a Posner covert orienting attention task. This is our colleague Greg Simpson. So that's not what I'm going to be talking about today, but it is something that situates a long-term interest since this is 28 years ago. We're going to talk about two studies today. The first part of this discussion will be on this recent paper in Brain Behavior and Immunity that's asking a question about what's the relationship between intensive focused attention meditation, inflammation, and performance on a cognitive task. And we're specifically looking at this concept of interference control. And that's the cognitive ability to suppress attention to task irrelevant features while heightening or attending to task relevant features. So in the context of perhaps mindfulness of breathing, that would be the sensations of your breath. And then in the task irrelevant might be, thinking about dinner if you're trying to follow the instructions. So we're also asking this question about what's the relationship between inflammatory activity and interference control. And there is a large body of evidence that suggests that inflammatory activity, circulating cytokines, are related to decreased performance on executive function tasks. And we're going to ask the question, does focused attention meditation in a retreat context work to improve interference control, either by perhaps decreasing inflammation or enhancing controlled attention? So there's a dual process model in conflict tests like the one I'm going to describe to you, where there are two aspects of what happens when you receive a stimulus. There's an automatic attentional alerting by features of the stimulus that may be task irrelevant. And there's an aspect that's the task set, which enhances controlled attention to the task relevant features. And controlled attention improves interference control, which is the inhibition of task irrelevant and the accentuation of task relevant information. And automatic attention alerting to task irrelevant features suppresses interference control. So can focused attention meditation actually impact this process, and which of these aspects of attention is changed by the meditation practice? This is a theoretical model, which I don't have time to go into, that actually puts many subcomponents of simply getting a stimulus and making a response in a framework, which you can go into in this paper by Grant Shields. So our two questions are, what is the role of focused attention meditation in interference control? And in this context, how does inflammatory activity affect interference control on this task? Now, we did a large intervention of 3-month residential retreat experience called the Shamatha Project at Shambhala Mountain Center. So if one is interested in contextual factors or architectural demand characteristics, it would be interesting to know that some of our participants could go through those double glass doors and meditate inside this stupa in front of a 20-foot high Buddha. What we did is we did 2 3-month retreats with randomized stratified assignment of 2 groups of 30 people in the spring and fall of 2007. And there was a control group that was flown to the retreat center 3 times, and then they did their own retreat. That's retreat 2. And where in this retreat experience, what was the practice? It wasn't MBSR. This was 6 hours a day of focused attention meditation, 7 days a week. It's taught by a Buddhist scholar, teacher, and translator, Alan Wallace. And there were 3 main practices on focused attention. Mindfulness of breathing, like what David just talked about, observing the events, mental events in the mind, and for paying attention to the quality of ongoing awareness. And there were about an hour a day practices of loving kindness, compassion, equanimity, and joy. We used a flanker task, which is simply your task is to say, is the center character an X or a Z? In the congruent condition, you just would say X, and the flanking stimuli don't interfere with seeing the X. In the incongruent condition, Now you have the Z's creating this automatic activation. And the performance on the task is to the degree to which your reaction time is slowed in the incongruent compared to the congruent conditions. We gave this task at the midpoint of these 3-month retreats. So we had a between group comparison after about 5 weeks of full-time meditation. And then we had a repeated measures design where the waitlist control group then did the task in the middle of their retreat that happened in the fall. We collected serum cytokines at the beginning, middle, and end of both retreats. And this is the computational model that Grant used to actually look at these data that has a gamma function of in red, which is the time course of the automatic alerting that maximizes itself shortly after the occurrence of a stimulus and works to slow you down and interferes with the accumulation of evidence of what is the correct answer. And then there's this linear drift in a Wiener diffusion model of the controlled attention component of the task. Surprisingly, when we just look at this reaction time difference, we see no effects of the retreat for either the first retreat between groups or the repeated measures. What about inflammatory activity? There's actually no significant group by time interaction in the first retreat. And when we look at the second retreat, we see no difference between the midpoint, between the control group and the control group when they went back to the retreat center and they did their retreat. However, when we do the computational model and we look at controlled attention versus automatic orienting, we find that there's actually a significant improvement in controlled attention in the retreat compared to the waitlist control group, and a significant improvement in automatic alerting. In the second retreat, we have a more robust replication of a change in the strength of controlled attention, but no change in automatic alerting. So the focused attention training appears to enhance controlled attention. The most important point of this study is that there's actually, for both retreats and across all participants, this increased inflammation is significantly associated with poorer controlled attention. When we look at a temporal priority analysis, we see that there is the cytokine levels at the beginning of the retreat significantly predict controlled attention at the midpoint of the retreat. But when we reverse the order and ask whether controlled attention at the midpoint of the retreat predicts inflammation at the end of the retreat, we do not see a significant relationship. So the takeaways here are utilities of computational modeling, improvements in controlled attention appear to be reliable effects of focused attention training, and it's possible that inflammation and the meditation are affected through different pathways. We need a larger sample to find out. And now I'm going to turn it over to my esteemed colleague, Quinn Conklin.
So I have about -10 minutes to tell you about some telomere and retreat findings. So I'm just going to zip right through, and you can find this in the Brain Behavior and Immunity paper that we wrote a couple of years ago if you're interested. So this is a follow-up to the Shamatha project that Cliff has led for years now, and it is in a 1-month retreat study at Spirit Rock Meditation Center, and we can talk again about the details of the retreat and what that context looks like afterward if you'd like. This is a photo of the retreat center where our participants spent a month in silent residential meditation training. So they spent about 8 to 10 hours a day practicing meditation and alternating between periods of walking and sitting meditation in a group of about 70 to 80 other participants during that retreat. So we also compared our retreat group to a group of control participants. We had about 30 folks in each group. Things are happening out of order here, so let's see. Okay. Let's see. And so we ended up with blood samples and telomere samples on about 25 people in each group from pre and post. The groups were balanced-ish in gender and age distribution. And this is a photo of us collecting blood at the retreat center and us processing that blood in the field laboratory that we set up to be close enough to the retreat center to process those samples quickly. And what we found was an increase in telomere length in the retreat group. So you can see from our pre to post time point, that gray line is the controls and we see very little change, but we see an increase in telomere length in the retreat participants. And Stacy has already cautioned us about the reasons to kind of not take this too seriously. We need a much larger sample size and there are pseudo lengthening issues and other things to consider. But tying this into the personality debate that we saw yesterday, one of the things that we found really interesting is that the increase in telomere length was not universal for all of the retreat participants. The folks that were most likely to see an increase in telomere length were higher in neuroticism or lower in agreeableness at the beginning of their retreat. So I've added those labels that Oliver John gave us yesterday about negative emotion regulation and amity. But unfortunately from this study, we can't decipher what is it that's carrying this effect. It's likely partly the meditation, but we also have to consider that retreat container as a whole. What is the context of the retreat? And we also don't know how long it lasts. So for this study, we don't have a follow-up. We did follow this particular study, Alyssa and Cliff and I, and our colleague Alexandra Creswell at UCSF put together a theoretical model and review of the 22 papers that exist on meditation and telomere biology. So if you're interested in finding out more, that's a good place to look. We are currently running a study looking at contemplative practice use for coping with the stressors of the pandemic. And I'm gonna hand it back over to Cliff to acknowledge our team and invite up our discussant.
So I'm basically a bit of an orchestra conductor of an extraordinary collaborative group. And we simply highlight here all of the investigators and trainees since we began the Shamatha project. Those folks whose work we talked about, I've highlighted. And this has had generous funding. And in terms of our discussant, we go back quite a ways. And so my dear friend and colleague, Richie Davidson.
Thank you, dear Cliff. And thank you all for an amazing symposium. When I think about the first papers that were published using randomized controlled trials to study meditation, they came out in the late 1990s or early 2000s, and it's really heartening to see the really extraordinary progress that has been made in such a short period of time. I want to just take a few minutes. I know we're coming up on dinner time. I know that you are engaging in very well characterized emotion regulation to sit here. But I'll just make a few points. The first is mindfulness was not developed to treat illness. And we need to just remember that. It was developed in a very different context. It was developed to deal with suffering, but not to treat specific illnesses. And so the fact that we are now investigating the impact of this kind of training in specific illness conditions is a historical first. It has never before been addressed in this way in human history. And so the complexity and the variation in the findings that we see should not be surprising. And it's the Dalai Lama frequently jokes that if mindfulness was so great for health, why is he still having such knee problems? So it's not going to be the panacea. And I think that's something that's really important for us to appreciate at the outset. A second really important issue, which was just indirectly hinted at by the whole panel, but wasn't explicitly addressed, is the issue of dosage. We saw a range of dosage in the talks, from the intensive retreat experiences that Cliff and Quinn and their colleagues have studied, to much briefer periods of practice. And even with the brief periods of practice, so for example, the beautiful work that David showcased, showing effects of just 20 minutes a day for 2 weeks, I think it was. If you do 20 minutes a day of practice, should you do it in one bout of 20 minutes, in 2 10-minute periods, in 4 5-minute periods? We have absolutely no idea. It's never been investigated. And that is a very important and practical question, and one that I think research needs to attend to, and probably the answer is going to be different for different kinds of people. And that is another really important issue, and that is one size is not going to fit all. And some people have often asked me in public talks, what's the best form of meditation that I should do? And the answer, I'll tell you, is it is that form of meditation that you actually do. And that's going to differ for different kinds of people. And we need to do the proper research to look at what kinds of practices are most beneficial for which kinds of people, which is starting to be done. And some of the predictors David mentioned, and Cliff mentioned some of the inflammatory predictors and psychological predictors of treatment response are going to be really important to continue to work on. I want to just mention maybe one other point, and that is David mentioned the use of smartphone apps, and this is something that is going to be an increasingly important addition to the armamentarium of methods that we have in this age of telemedicine and digital health. And I think it has many challenges and all kinds of downsides, but it also has a lot of upsides. And I think that it is going to be an exciting opportunity because it will allow us to collect data in very large sample sizes, the likes of which have never been done before, and to monitor the practices in a way that does not exclusively rely on self-report. And there is one other thing that I'll mention, since I did mention the not relying exclusively on self-report, and that is, this is a field that desperately needs better measures. So actually, I'm going to say 2 more things quickly. Everyone's talking about mindfulness and the measures that we all use, and we are guilty of the same thing where we are using self-report measures where data in the literature suggests that Thai Buddhist monks perform more poorly on a self-report measure of mindfulness than binge drinking college students. And it just calls into question some of the validity of these measures. And so we need to do a better job of developing these measures. So I'm actually going to end there, and thank you for your attention, and have a great dinner.
Like dessert before dinner. Thank